I'm Dr. Katherine Hamilton. I am a headache specialist at MedStar Georgetown University Hospital, and I see only headache patients, and that consists of patients with all different types of headaches. A lot of my patients have migraine, but there are also patients with tension headaches or musculoskeletal issues, also more rare types of headaches like cluster headaches. I see all types of headaches. I try to really spend the time to listen to the patient and hear what their desires are and their goals are coming into a visit, because migraine and headache treatment can be complex. There are a lot of different options. There are non-medication and medication approaches, and it really depends on the patient sitting in front of me how I'm going to treat them for their headaches. That is a huge factor in how I end up treating them. You really want to work with them to figure out what is the best way to manage that particular patient's headaches and migraine. MedStar Georgetown University Hospital has one of the larger headache groups in the country, and that larger group allows us to take a multidisciplinary, comprehensive approach to our patients. I have colleagues that I can call on or discuss with if a patient's case is more challenging, and that really allows more comprehensive care. And along those lines, there are a lot of colleagues even outside of our immediate headache group in other specialties like physical therapy or ENT, neurosurgery, that I work closely with here. And that's another benefit of getting care at a larger headache center and in an academic center, is that there are a lot of other specialists who can weigh in and who we work closely with in helping headache patients. It's incredibly rewarding to help these patients. These are often patients who are otherwise healthy, who are pretty high functioning, and migraine and other types of headaches can be really debilitating for them, can really prevent them from living their life. So I found it incredibly rewarding to provide them with treatments that can help them get back to their life, get back to functioning and contributing to their family and their work. Migraine is a specific type of headache. It's one of the most common diagnoses that we treat as headache specialists. A migraine headache tends to be more severe. It's often one-sided, throbbing in nature, but a migraine is much more than just a headache. During a migraine attack, patients can have a host of symptoms such as dizziness, light sensitivity, nausea, vision changes, cognitive impairment, fatigue. So it's really much more than just a headache. And migraine is really a disease, a disorder of the brain. There are certainly a lot of things left to discover about the mechanisms of migraine, but we've made great strides in understanding some of the mechanisms going on in the brain during migraine. And we understand that it's a complex process. There are genetic and environmental factors, but the more and more we understand, it allows us to develop new treatments, more targeted treatments for migraine. Migraine is diagnosed based on the symptoms that a patient experiences. So if a patient has a severe one-sided throbbing headache with associated nausea and light sensitivity, that's enough to make the diagnosis of migraine. We don't necessarily need to look for a certain imaging finding or a certain blood test to make the diagnosis. Although sometimes if someone is having headaches with unusual or atypical features, then we might want to get a brain MRI just to rule out other causes of headache. We treat migraine headaches in a variety of ways. there are non-medication and medication approaches. So before even talking about medications, I like to talk to patients about non-medication approaches, things like minimizing stress, avoiding triggers, keeping sleep schedules regular, trying to get enough sleep, staying well hydrated. And then in terms of medications, there are two different types. There are preventive medications or treatments. The goal of preventive treatments is to lower the frequency and severity of migraine. So these are particularly important if someone is having very frequent or severe migraines. And then there are as-needed or acute treatments, treatments to take at the start of a migraine or to treat a migraine in the moment. So typically for a patient with migraine, we are using a combination of non-medication and medication approaches, both for prevention and as needed. And in addition to medications, there are also procedures, there are devices we can use. So it's really a wide range of treatment options. There are a lot of newer, more targeted migraine treatments that have come out even in just the last few years. And some of these treatments are in trials and are not available to the public, but could be available if a patient were to enroll in a trial. So by having access to those clinical trials here, that expands treatment options for patients, especially for patients who have tried a lot of treatments in the past and not had success. Migraine is much more common among women. Interestingly, in young girls and boys before puberty, there's equal numbers with migraine. But after puberty, migraine becomes 2 to 3 times more common in women. So clearly there is a hormonal factor at play here. Migraine can often shift and change over the course of a woman's life based on hormonal changes. So for example, sometimes women first start to get migraine when they start to get their periods, and often migraines can be more frequent or severe around the time of the month of the period. Migraines often can improve during pregnancy, and likewise they can sometimes improve after menopause. So knowing this will help guide our treatment of women with migraine as we know what to expect or potentially anticipate as they move through their lifespan. Migraine can often be worse around the period because of the drop in estrogen that occurs. So knowing that mechanism, it can help us treat menstrually related migraine or prevent menstrually related migraine. What we'll do sometimes is we'll treat a woman with estrogen-containing birth control pills to try to keep those estrogen levels more stable. Sometimes we'll even have them take birth control pills continuously so they avoid their period altogether, and that can try to prevent those menstrually related migraines. There are also non-hormonal approaches to treating menstrually related migraine. Sometimes we use an as-needed medication like an anti-inflammatory, and we have the woman take it every day around the time of their period to keep the migraine headaches at bay. So for example, if the woman knows that she's going to get a migraine headache at the first day of her period, she can start taking the medication the day before and continue taking it through that period of time. So this is a very important thing to bring up with women and to plan and counsel them on well before they get pregnant, because you want to have a good plan in place for migraine treatment. So I always ask my female patients whether they have any plans for pregnancy in the next 6 months, because I want to know well in advance so that we can come up with strategies and plans. The good news is that for many women, migraine gets better in pregnancy, and this is because they're not having those hormonal fluctuations that come around the period. It's just a rising level of estrogen throughout the pregnancy. So particularly in the second and third trimester of pregnancy, migraine can be much improved. However, that's not to say they won't have migraine during pregnancy. And for some women, unfortunately, migraine does not improve, so we still need to have good treatment options. A big point I try to make is that there are options. We're definitely more limited when it comes to treating migraine in pregnancy, just because a lot of the medications do have potential risks for the pregnancy, but there are certainly safer options, and there are some good non-medication options as well. So I try to counsel women that that we can take a tiered approach. We have options. We can try different things, but they shouldn't feel that there's nothing at all that they can take. We are more limited with what medications and treatments we can use in pregnancy, because with a lot of medications there are concerns for their use in pregnancy, for their effects on the pregnancy itself or the fetus. And unfortunately, for a lot of treatments, we just don't have a lot of data. Pregnant women are usually excluded from randomized controlled trials, so we don't have the same kind of data that we would have for non-pregnant patients. That being said, there are certain treatments that are considered safer, and we do have data from what we call retrospective studies, or studies that look back in time at women who have taken medications during their pregnancy. So there are certain medications that we consider safer in pregnancy. And there are also non-medication options that don't lead to anything getting into the body, that are considered safer in pregnancy. For example, procedures like nerve blocks or botulinum toxin A, Botox, or there are certain devices that we can use for migraine treatment. So I like to go through some of those safer options with patients. The postpartum period can be a challenging time for migraine because there are a lot of hormonal shifts that happen. A woman is usually sleep deprived, stressed from caring for a newborn. So all of those can be potential migraine triggers. And the good news is that in the postpartum period, we do have more treatment options, more safe treatment options for migraine, even if a woman is breastfeeding. So while migraine might pick up a little bit after a woman delivers her baby, she at least has more options to use for both preventive and acute treatment. Also, breastfeeding itself can sometimes be protective, can sometimes help to keep migraine frequency lower, because it prevents those monthly fluctuations that happen that can be a migraine trigger. These CGRP treatments are newer. They've been around for a few years now. These are more targeted migraine treatments that work based on the mechanisms that we understand about migraine. They block this certain molecule called CGRP. Because they're newer, we just don't have a lot of data on their use in pregnancy, so we don't know whether they're safe. We don't know whether they might have adverse effects. So for that reason, right now, we don't use these newer medications for a woman who's pregnant or breastfeeding. And usually we want to make sure that a woman has stopped it before she gets pregnant, so that she's not exposed at all during the pregnancy. For some of these newer medications, some of them are once-a-month injections. We have to stop those months before a woman gets pregnant, because it takes a little bit of time to get out of the system. So it's important to know, if you're on one of these newer migraine medications, to mention to your doctor if you're at all thinking about pregnancy in the next 6 months or so. Oftentimes migraine does improve after menopause, and that's because the hormones even out and stabilize at low levels, so you're no longer having those fluctuations of estrogen that can trigger migraine. That's a general or most common scenario for a woman, especially for a woman who's had menstrually related migraines or hormonally related migraines. However, that's not always the case. doesn't always improve after menopause. And sometimes migraine headaches can shift, and a woman might have improvement in the headache, but still have episodes of migraine involving dizziness, nausea, other associated symptoms. I've definitely seen that. So it's not to say that after menopause you don't have to worry about migraine. It's still something that can come up. And in the period of time leading up to menopause, the perimenopausal period, that can actually be a time where migraines worsen because there are more fluctuations of estrogen. So it's important to be aware of that and counsel the woman that period of time, that perimenopausal period, can actually be quite long. So you don't want to think, oh, I've had my last period, I won't get a migraine again, because sometimes, if anything, migraine can get a little bit worse before it gets better. This is definitely an area where we need more research. There have not been a lot of studies on treating perimenopausal migraine specifically. In general, we treat it similarly to how we treat migraine in other periods of life. One important concept is just to understand that migraine can get worse around that time. So oftentimes this is a point at which women will need to start a preventive medication for their migraine. But typically we use similar preventive and acute medications as we would at other times. Some of the preventive migraine medications can actually also help with other perimenopausal symptoms. Sometimes we can target our medication choices to include other symptoms to target for that occur during perimenopause. Sometimes patients will start hormone replacement therapy. We usually don't start that simply because their migraine frequency is higher, but if someone is having other symptoms like hot flashes, that might be something that they could discuss with their gynecologist. Patients should choose MedStar Georgetown University Hospital Headache Center because we have one of the largest headache groups in the whole country. We have many headache specialists who have different areas of expertise, and that large group allows for really great collaboration and really comprehensive patient care. So a patient will know that even if their case is more complex, they have not just their own doctor, but a whole team of doctors behind their care and working to help their headaches. It's also a multidisciplinary group. There are specialists outside of neurology that we work closely with, like physical therapy or neurosurgery. So we have a very extensive, larger network of providers helping to care for headache patients, and that also makes MedStar Georgetown University Headache Center unique.